Hello, everybody. Hope that you're doing well. This week, we're going to move forward with ventilation. If you recall, last week we went over the mechanics of ventilation. So ultimately, everything that goes into getting that air in and out of the lungs. Now we'll kind of break things down and actually talk about the air uh, that is going into it. So we know that in atmospheric air, if we're talking about at sea level, atmospheric pressure of 760 millimeters of mercury, 764. We also know that the composition of the air that you and I breathe in roughly uh, will round up to 21% oxygen, and then we'll round up to 79% nitrogen, but it's also roughly 21% oxygen, 79% nitrogen, and then you've got a very small percentage of other trace gases that tend to go up, but the overall composition, looking at mainly oxygen and nitrogen with the air, or what we consider to be room air that you and I are breathing in and out of our lungs. So let's see if I can activate this annotation feature right quickly. And we'll, what they say, but when I go through the drawing. So if we've got air out here in the atmosphere, when the patient takes that breath in, so when we have the mechanics of ventilation and you've got the pressure changes and stuff, that the diaphragm contracts, pressure changes take place. Then patient takes a breath in, whether breathing into the mouth, breathing into the nose, that air is going to go into the mouth, go into the nose. You'll have everything connect at this point. And when they breathe in, that air is going to fill the oropharynx, nasopharynx, or the nasopharynx, oropharynx, pharynx into the trachea. Then that air has got to be split at the area at the bifurcation of the tracheobronchial of the trachea into your right main stem bronchus, left main stem bronchus, and better easily depicted on the patient's right side over here. Then anywhere there's an airway, go ahead and shade that in blue. Now remember, blue is going to be indicative of the air that we've breathed in. So I won't waste your time in trying to highlight all of it, but you can see what I've done thus far. And we also know that at the distal end of the terminal bronchioles, you've got air sacs referred to as alveoli. And that's where we want the air that we breathe in to get to so that gas exchange can take place. Remember, in the past, we'd also talk about external and internal respiration. External respiration is going to be a reference to the exchange between oxygen and carbon dioxide that takes place in the lungs. But ultimately, what I want to try to uh, impress upon you right now is with ventilation. Yes, air goes in, and air should come back out. Uh, but ultimately, let's pretend that this section of air that I drew outside of this patient's face represents an average tidal volume for your normal healthy adult of roughly 500 milliliters or cc's. 500 mLs, 500 cc's, half a liter, however you want to look at it. 500 milliliters is going to go down into the patient's airways and ultimately to the lung. What I want you to understand is that although I breathe in 500 milliliters of air, not all 500 milliliters of that air make it to the alveoli. So that's something that we've got to make sure you can understand right off the bat. Whenever you take a breath in, a portion of that breath will be left in these airways, and then only a portion of that breath is going to make it to the alveoli, if that makes sense. So if I take a breath in, I don't have anything to flush that air that's left on. So when I take in that breath and those pressures equilibrate, remember when those pressures equilibrate, flow stops. So the flow has stopped, but that don't mean that all of that flow or all that volume made it to the alveoli. You will have some of that left in the trachea, you'll have some of that left in the larger airways, the smaller airways, and only a portion of that 500 milliliter tidal volume actually makes it to the alveoli. So that would be, so if we're talking about one breath and you take in a tidal volume of 500 milliliters, then a portion of that volume make it to the alveoli. So you will have an alveolar volume. So if you're going to calculate minute ventilation, I've got this on slides to come, but your minute ventilation is respiratory rate times tidal volume. If you want to figure out what your alveolar ventilation is, then you got to take into account the dead space ventilation and subtract that from the overall minute ventilation. And then what's left over should be the volume that's getting down to the alveoli. When we talk about dead space, the anatomic dead space, the physiologic dead space, and we talk about those as we move forward. But I just wanted to kind of highlight this with the illustration before we get going, because you need to understand that when you take a breath in, whether it's a 400 milliliter tidal volume, whether it's a liter tidal volume, the number associated with what we're breathing in does not actually make it all the way to the alveoli. So we're going to focus later on the effective portion of the tidal volume, which is the portion that gets down to the alveoli, because it's important to understand that the only effective ventilation is alveolar ventilation, because that is the portion of the breath, the portion of the volume, portion of the tidal volume that is indeed going to participate in gas exchange. So let me clear this and we'll go ahead and get moving forward. So we do want to make sure that we understand our four vital life functions, and in order, they are ventilation, oxygenation, circulation, and perfusion. And to go back to kind of reiterate what we were talking about, minute ventilation, and you'll notice minute ventilation is going to be a capital V with a subscript E with a dot over the middle of the V, and that is going to be in reference to our minute ventilation. So you've got the total amount of air that moves in and out of the lungs over the course of a minute. So if you take your respiratory rate and multiply that by your tidal volume, then that's going to give you the answer of how much volume gets circulated through your lungs within 1 minute. So if we're looking at basing things off of norms, and for the sake of keeping math relatively simple, change colors up again. Now, so if I have a respiratory rate of 12, and I'm going to multiply that by roughly normal tidal volume of 500 milliliters, then that's going to yield my minute ventilation of 6,000 milliliters. Or you could do it like this: 12 times, we know that 500 milliliters is half of a liter, 0.5 liters, going to give me a 6 liter per minute. And that can be per minute as well. Per minute ventilation. So this means if I breathe 12 times per minute, each of those breaths I'm breathing in 500 milliliters. Over the course of a minute, I have essentially moved 6,000 milliliters or 6 liters per minute, 6 liters of volume in and out of my chest within that minute. So that is our minute ventilation. But notice that if you think back to what we started with at the beginning of the presentation, not all of that volume, not all of that 6 liters actually makes it to the alveoli. So we've got to look into the process of taking out that anatomical dead space. If you happen to have the physiologic dead space or alveolar dead space, and hopefully you don't have many situations that you're going to encounter under normal circumstances where the alveolar dead space, that alveolar dead space can exist, but it is abnormal for it to exist, if that makes sense. So we want to talk about those items here as well. But everything's going to come back to ventilation. If you're not ventilating appropriately, it's going to be difficult for the other things to fall into place. So there are 4 vital life functions. You've got ventilation, oxygenation, circulation, and perfusion. So if we look at a couple of things that we're going to discuss next week, we're going to be moving into pulmonary blood flow, which we will talk next week more extensively about shunt. But right now, I think it's important because it's important to understand the differences in the two. So dead space is ventilation without perfusion. Dead space is ventilation without perfusion. Shunt is perfusion without ventilation. So, when you begin to think about your pathophysiologic states and stuff of that nature, it helps to understand what dead space is and what constitutes a dead space unit versus what constitutes something that would cause shunt to occur. So, for instance, we've talked about anatomic dead space, ventilation without perfusion. So if you have the air moving in and out of these airways, it would make sense that air did come into the trachea, air went into the right mediastinum bronchus, air went into the left mediastinum bronchus, air has gone into the different segments of the left lung, air has gone to the different segments of the right lung, the airways within the segments. That gas itself did not participate in gas exchange, so that would comprise part of our anatomic dead space. Ultimately, the text says that you estimate about 150 milliliters of anatomic dead space for the normal individual. Or if you're not going to go off of the estimation of 150 milliliters, then you can deduce that your dead space should be roughly 1 milliliter per pound of ideal body weight that the individual has. You can recall the ideal body weight equation, a little different for a male versus female, but it's the exact, but it's pretty much the same setup. You can remember 106 and 105, you should be able to remember the formula. So for a male, it's 106 plus 6 times height inches. Not let me write that out because the order of operation is gonna matter to an extent. So as far as ideal body weight is concerned, you IBW 106 plus 6 times height in inches minus 60. And that's for a male. And then we have IBW equals 105 plus 5 times height in inches minus 60, and that is for female. Now, keep in mind, this is going to give you your answer in pounds, which we said 1 milliliter per pound, and that's all well and good. But once we transition to mechanical ventilation, you'll need to make sure that you're remembering to convert that pound to kilograms and divide that by 2.2 in order to do that, because the volumes that we're going to teach when we get to mechanical ventilation are to be able to establish 6 to 8 milliliters per kilogram of ideal body weight. And you're probably going to hear some individuals utilize predicted body weight as well, and that's fine. We'll go over that in a subsequent session. But nonetheless, important to be able to estimate or calculate someone's ideal body weight, because if you're not going to utilize 150 as it depends upon how the question's asked. If it tells you that your anatomical dead space is 150, then you can subtract that from the tidal volume. That should hopefully link you with what your ventilation is going to be and so forth. But if not, if you're given a patient's height, so to speak, then you can calculate and estimate that 1 milliliter per pound of body weight is going to be what the anatomic dead space would be. Because ultimately, if I were to say that I take in a tidal volume of 500 milliliters, and we say that that patient has 150 cc's of anatomical dead space, or milliliters of anatomical dead space, and you go into the math, and that means of that 500 cc's that you took in, the 500 milliliters that you took in, only 350 that actually made it to the alveoli. So if for all intents and purposes, if we're doing it that way, then we would say that our alveolar volume for that point would be 350. So case in point, if you were to take a respiratory rate of 12 and multiply that by 500 milliliters, we've already established that gives us a 6.0 minute ventilation, 6 liter minute ventilation. But now if you're looking at the alveolar ventilation, you're still going to take that same respiratory rate, and now you've knocked that down to 350 or 1035, however you prefer to do the math, and then you're going to get an answer that's less than 6.0. So I'll do that right quickly on my calculator. 12 4.6. So our alveolar minute ventilation is 4.2 liters per minute. That's going to be important because later on you're going to be tasked with questions. Once we get into mechanical ventilation, we've got a patient that is hypercapnic and we need to achieve better ventilation for that individual. And we're going to need to know how to manipulate our tidal volume and or our respiratory rate to be able to achieve the removal of more CO2. So for the purposes of this lecture or this information that we're going over, ventilation is going to be air moving in and out of the chest. But when I say ventilation, we're also going to utilize that as reference to the amount of CO2 removal. So if we increase ventilation, we're going to increase CO2 removal. If we decrease ventilation, we're going to decrease CO2 removal, carbon dioxide. So look at that as well. So we covered dead space. Shunt is perfusion without ventilation. So ultimately, if we got into a situation where, for whatever reason, let's say, and although it's not drawn on each of these, you have this capillary network that surrounds each of these alveoli, and it would look very similar to this around every alveolus that you have. So naturally, when the air that we breathe in has oxygen, and that oxygen is going to come in to the alveolus, and then we're going to have oxygen will go into the bloodstream, and carbon dioxide is going to come out of the bloodstream. The exhale to blow out that CO2, and you breathe in to take them in the CO2, and we've gone over blood flow, the heart too as well. So we know that that oxygen blood is now going to be returned by way of the pulmonary vein back to the left atrium, so that it can be cycled through the left part of the heart into the systemic circulation and out through the rest of the body, so that you can have the internal respiration that will occur. But if we have an area of shunt, what's going to happen now is, let me draw in. So this alveolus or this cluster of alveoli get a situation to where they become consolidated, they become atelectatic, or closed down. They are not receiving ventilation. Mind you, you're still going to have the capillary network that goes around them. So they're still going to receive perfusion, but they did not receive ventilation. So perfusion without ventilation is shunt. And what is the end result of shunt? Well, I have blood now that was deoxygenated that is hoping to go around this alveolar unit so that it can be reoxygenated or pick up more oxygen and drop off the CO2. Well, if CO2 can't come out, the O2 can't go in. So you get into a situation where you're going to have lower PaO2 value and maybe potentially higher CO2 values depending upon the overall significance of the area of shunt. You can have anatomic shunt. Remember back to your min-80 course when you went over the fever circulation, the 3 different shunts that we heard. So anytime you encounter those shunts, you've got deoxygenated blood moving forward without being oxygenated, or the mixing of the two. That's ultimately going to mixing the two, being oxygenated blood mixing with deoxygenated blood. That's ultimately going to lower the amount of oxygenated blood that's available in systemic circulation. So we'll clear that drawing and we'll move forward as well. Here we'll talk about the overall effectiveness of ventilation. So the adequacy of ventilation. So effectiveness and adequacy of ventilation essentially mean the same thing. So if I'm looking at the ventilation, they said that ventilation is going to be for CO2 needs. Well, if you think about your blood gas values, pH is 7.35 to 7.45, PaCO2, partial pressure of arterial carbon dioxide is 35 to 45 millimeters of mercury. Your PaO2, your partial pressure of arterial oxygen, is 80 to 100 millimeters of mercury. Your bicarb can be 22 to 26 milliequivalents per liter, like a base excess plus or minus 2, and then an SaO2 hopefully about 90%. Well, we'll think that. But we'll focus on the ventilation component of the blood gas right now, and that is our PaCO2. So when we talk about the overall effectiveness or adequacy of ventilation, you're going to assess the patient's PaCO2. Understand that normal range is understand that normal range is 35 to 45 millimeters of mercury. Then we know that if we happen to have anything above, so if our CO2 is above 45 millimeters of mercury, we are ineffective. Our ventilation is ineffective. It's not effective. Meaning we are not blowing off an adequate amount of CO2 to maintain within the 35 to 45 millimeter mercury range. So if our CO2 goes up, that is going to be called hypercarbon. Hypercarbon. You may even see it listed as hypercarbon. Excuse my handwriting's not very good. But notice that hypoventilation results in hypercarbon or hypercapnia. So if a patient's hypoventilating, they're not breathing well enough to remove the CO2 from the blood, so their CO2 levels are going to come, so they become hypercarbon or hypercapnia. And that is a result of hypoventilation. Then if we look over here where CO2 is less than 35 millimeters of mercury, then this makes us hypocarbon or hypocapnia. And then that's going to be a situation where we are hyperventilating. So hyperventilation results in excessive CO2 emission. So here we are effective. Here we are ineffective. And over here we are overly effective. When we get to our acid-base disturbance, which we'll do another presentation on blood gases. But as far as CO2 is concerned and pH, your PaCO2 is going to be inversely related to your pH. So the respiratory component of the blood gas is the PaCO2, and in relation to the pH is going to have an inverse relationship. So then if PaCO2 increases, then pH will go down. If PaCO2 decreases, then pH will go up. This is a respiratory acidosis. This is a respiratory alkalosis. That will be more important as we get into blood gas interpretation, when we get into mechanical ventilation and move forward from there. But it's important to understand the overall effectiveness of ventilation and the importance that the CO2 plays in the effectiveness of ventilation. So effectiveness of ventilation, CO2 35 to 45 millimeters of mercury. But ineffective, CO2 is going to climb up. You get into a hypercarbonic or hypercapnic state, get into a situation where your CO2 is less than 35 millimeters of mercury, you get into a hypocarbonic or hypocapnic state, and then CO2 is lower than that. You're hyperventilating at this point. So we want to make sure that we have an understanding and appreciation for that. So when you clear that, looking at the overall efficiency of ventilation. So it is possible that you can have effective ventilation, but not efficient ventilation. And if you take into account the things that can alter your efficiency of ventilation or your VVT, so that's ultimately when you look at the ratio of your bed space volume that we talked about to the overall tidal volume that's taken in. So if VDVT, if the numeric value for that tends to creep up, chances are the overall work will do the patient having to breathe a lot harder, and there's going to be more wasted dead space, ventilation, if you will. So rate, depth, you know, if you take into account patient breathing like that, they may very well be able to get, if you're looking at blood gas values or what have you, be able to breathe in such a manner that gets them to an effective portion of the blood gas where our blood gas, the CO2s are lower than where we need to be. But if you take into account the physiologic aspect of what they're having to do to achieve that, their ventilation may be effective, but it's not efficient. Ultimately, when you go through and do this, you're looking at a third of that volume or 33%. Uh, uh, the kind of the spot where you want to keep that DVDT at. And you recall the Bohr equation. The Bohr equation is exactly what we have listed here, where you take the PaCO2, subtracting that your PeCO2, and divide that by your PaCO2. So effective ventilation, efficient ventilation, they're not equal, but it would be nice if we're taking care of the patient to provide not only effective ventilation, but efficient ventilation as well. And, you know, that's where some of our other therapeutic adjuncts are going to come in and maintaining a perfect clean air toilet and so forth. Super important to understand not just the mechanics of ventilation, but ventilation of itself, knowing that, yes, you've got a total, like if you set a respiratory rate of 12 and a tidal volume of 500, you know that your set minute ventilation is going to be 6 liters. However, you need to understand that there are pathologic states, disease states, and what have you, that are going to alter the ability of the lungs to function effectively or efficiently. And then also have an appreciation that not all of that 6 liters makes it to the alveoli. So you've got to remember to take into account the removal uh, of that dead space volume, so that you can understand that the alveolar ventilation, the alveolar volume, and the alveolar ventilation is the effective component of that, and going to really help to assist removing your CO2. So we'll go over this in heavier detail during class, but this is the overview that I have to provide you for, and I thank you all for your time and attention.